Hi, my name is Christie Reining, and this is my geriatric syndrome case presentation on falls. Falls are defined as the unintentional loss of balance that results in a position change and contact with the ground. They're the leading cause of injury in adults aged 65 years and older. The risk of falling increases with age for many reasons, including overall weakness and frailty, balance problems, cognitive problems, vision problems, medications, acute illness, and other environmental hazards. The best predictor for an increased risk of falls is a history of falls. Falls threaten senior safety and independence and generate enormous economic and personal cost. Through lifestyle adjustments, falls prevention programs, and community partnerships, the number of falls can be substantially reduced. Did you know that 1 in 4 Americans aged 65 and older fall each year? Every 11 seconds, an older adult is treated in the emergency room for a fall, and every 19 minutes, an older adult will die from a fall. Falls are the leading cause of fatal injury and the most common cause of non-fatal trauma-related hospital admissions among older adults. In 2018, the total cost of fall injuries was $50 billion. Medicare and Medicaid covered 75% of those costs. Incidence rates in hospitals and nursing homes are almost 3 times higher than that of community dwelling persons aged 65 and older. Elderly falls can be effectively prevented by identification, evaluation, and implementation of interventions by nurses that reduce falls in the elderly. Home assessment of community dwelling elderly at risk for falls and assessment of high-risk residents in nursing homes can also help prevent falls, along with relevant referral to other specialists and agencies as needed. My case study was done on a 74-year-old community dwelling male. He has allergies to shellfish and iodine. He's up to date on all his immunizations, including PCV13, PPSV23, shingles, influenza, Tdap, and has had all his childhood vaccinations as well. He's on a current list of medications, which you can see here to the right, that treat for diabetes, Parkinson's disease, high blood pressure, high cholesterol, acid reflux, BPH, restless legs, and high triglycerides. Past medical history for ER. Comorbid conditions include diabetes, hypertension, hyperlipidemia, BPH, acid reflux, restless leg syndrome, obesity, sleep apnea, Parkinson's disease. He was hospitalized for a gastric bypass 2002 and a repair of his left quadricep muscle in 2016. He lives in a double-wide trailer in a rural area with his wife and family. Typical presentation for ER includes he is obese, well-developed, usually in good spirits. His wife usually accompanies him to his office visits. He appears to have difficulty sitting and standing and uses a walker when ambulating. Common complaints for ER. His decreased mobility started after his first fall in 2016, where he tore his left quadricep muscle. He had a surgical repair, was inpatient for rehab for 6 weeks, and ever since has used an assistive device to help ambulate. He was diagnosed with Parkinson's disease in 2018, which further limits his mobility. He also reports a second fall approximately 3 weeks ago when he was getting out of bed to use the bathroom at night. Health promotion and disease prevention for ER include that he is a non-smoker. He denies current or former use of alcohol. He keeps all his scheduled appointments. He complies with blood glucose monitoring schedules, wears his shoes except when he's sleeping, uses his CPAP every night, takes his medications as prescribed, and says that because his wife is a former RN, she keeps him in line. Pertinent review of systems that I want to point out. are shortness of breath with exertion, pleuritic chest pain, swelling of his hands or feet. He complains of shortness of breath with exertion, cough, chest discomfort, wheezing, complains of urinary frequency, urgency, and nocturia, complains of joint pain and arthritis and loss of strength, complains of disturbances in coordination, dizziness and tremors, complains of easy bruising, and seasonal allergies. Some physical exam findings I'd like to point out for ER is that he is obese, decreased breath sounds to his right upper lobe. He had pedal and tibial edema, 3+, but did not have any sacral edema or varicosities or stasis ulcers. His strength was decreased in his extremities. With coordination, I was unable to assess his tandem gait or heel-to-toe walking. With the walker, his gait was wide and poor balance was exhibited. Get up and go test resulted in a time of 30 seconds with the use of assistive device only. I was unable to assess the Romberg or sternal shove due to his use of or need of the assistive device. Light touch and pinprick were limited in both feet. His cognition was intact and all his cranial nerves appeared to be intact. Vital signs for ER appeared to be within normal limits. He's 5'9½". He weighed 381 pounds at this office visit, which was a change of plus 3 pounds from his last office visit. He has a BMI of 55.5. Pulse was 52, rhythm was regular, but states that his pulse normally runs low in the 50s. O2 sat was 97% on room air, and his orthostatic vital signs did not show a significant difference. Screening tools used for ER were the Tonetti Gait and Balance Scale, which he scored a 12 on, which indicated a risk for falls. The Get Up and Go test, he scored 30 seconds, which also indicates a risk for falls. He had a perfect score on the mini mental statics exam, and the geriatric depression screening, he scored an 8, but stated he was not interested in adding another medication to his regimen at this time. He did not feel that that would be smart to do since he's already on so many medications. Diagnostics ordered at this visit were spirometry, and that was to rule out lung diseases since he was complaining of such severe shortness of breath. And then also a brain natriuretic peptide to assess for heart failure. He had 3+ pedal edema and shortness of breath and does not have a prior or previous diagnosis of heart failure. A history of falls and performing a fall-related assessment are likely to reduce future probability of falls when coupled with appropriate intervention, according to the American Geriatric Society. Older adults living in their home would benefit from interventions such as gait training and the appropriate use of assistive devices, review and modification of medication, exercise programs with balance training as one of its components, treatment of postural hypotension, modification of environmental hazards, and treatment of cardiovascular disorders, including arrhythmias, also from the American Geriatric Society. Some other potential interventions include frequent vision assessment and remediable treatment as necessary, and wearing appropriate footwear. Differential diagnoses for ER include dementia, delirium, orthostatic hypotension, polypharmacy, and sensory impairment. To rule out dementia and delirium, I completed a mini mental statics exam, which he scored 30 on, which showed no evidence of cognitive impairment. To rule out orthostatic hypotension, his blood pressure was taken while sitting, standing, and lying down and did not show a significant difference. To rule out polypharmacy, an evaluation of his medications were completed, and If necessary, I would prescribe medications as needed. To rule out sensory impairment, performing a neurological, sensory, and motor examination at each visit is necessary. Final diagnoses for ER include hypertriglyceridemia due to his elevated triglyceride level, diabetes mellitus from a fasting blood glucose of 127 and a hemoglobin A1C of 6.6, unspecified anemia due to a hemoglobin of 9.8, shortness of breath due to patient report and physical exam, and edema due to patient report and physical exam. Barriers and challenges to implementing the plan of care were the inability to confirm the diagnosis at today's visit. A spirometry and BNP had to be ordered to hopefully confirm diagnoses at a later date. And then lack of time during the office visit to educate the patient extensively on potential diagnoses and also health promotion. So this patient is already receiving several services from community resources, including physical therapy, housekeeping, caregiver services, medication assistance, VA services, and mobility assistance. I believe he could further benefit from a thorough home safety evaluation by PT and then assistance with fixing any safety concerns as needed. He'd also benefit from connection to a diabetes educator or nutritionist that could give him and his wife recommendations to help him prepare meals that more closely follow recommendations for a diabetic diet, a diabetic patient with cardiovascular issues. He's already receiving services from specialists such as neurology, cardiology, physical therapy, and a geriatrician at the VA, along with the primary care services he receives at this clinic. A multidisciplinary approach to care results in greater patient satisfaction with the treatment, improved financial performance, a reduction in the duration of hospitalization, and a significant reduction in the number of unplanned hospital readmissions. I commended ER on the health behaviors of never smoking or consuming alcohol, and then health behaviors that were addressed that need improvement are diet, exercise, and eliminating salt from the diet. Social determinants of health for ER include that he's financially stable, he and his wife are living on Social Security benefits, and a savings account that they've saved for their entire lives, and that he's receiving free medical services from the VA. Legal and ethical issues. The elderly often have an ambivalent view of fall prevention, and this ambivalence often stems from the perceived need for safety and protection from injuries on the one hand, and the need to preserve their autonomy and independence on the other hand. Their willingness to comply often depends on how they weigh those needs. And restraint measures are often implemented in long-term care facilities that don't take the individual's preference regarding those restraints into account, which can often lead to legal ramifications. And then not addressing factors that could result in falls can also be a legal issue for providers. So what did you learn? By being a proactive provider to the elderly at risk for falls, we can decrease the incidence of falls extensively. The United States Preventative Services Task Force found adequate evidence that exercise interventions have a moderate benefit, grade B, in preventing falls in older adults at risk for falls. The United States Department of Health and Human Services recommends that older adults get at least 150 minutes per week of moderate intensity or 75 minutes per week of vigorous intensity aerobic physical activity, as well as muscle strengthening activities twice per week. It also recommends performing balance training on 3 or more days per week for older adults at risk for falls because of a recent fall or difficulty walking. Older adults should be assessed for falls at each office visit. And treatment for elderly reporting a fall should include combinations of exercise, psychological interventions, nutrition therapy, knowledge, medication management, urinary incontinence management, environmental mental modification, and referrals to physical or occupational therapy, social or community services are specialists such as ophthalmology, neurology, and cardiology. The United States Preventative Services Task Force recommends against vitamin D supplementation to prevent falls in community dwelling adults age 65 and older because evidence does not show that it reduces risk for falls, and high doses of vitamin D causes more harm than good for patients. Thank you for listening, and I hope you've enjoyed this presentation.